Everyone, welcome to the channel. In today's video, we will learn about the intrauterine devices and we will discuss their classification, advantages, disadvantages, and when to remove it and what to do if the thread is missing. I have made a separate video regarding the insertion of intrauterine device in which I have discussed the technique in detail. If you want to check out the insertion detail, you can also check that video along with the present one. So if we classify our intrauterine devices, they can be categorized as non-medicated IUDs or medicated or bioactive IUDs. So non-medicated IUDs are also known as inert IUDs, and examples include Lippes loop and Grafenberg's ring. Among medicated IUDs, or also known as bioactive IUDs, either they can include the metallic ions like copper, or they can be hormone containing intrauterine devices. So inert IUDs are also known as first generation IUDs in which no medication is added. So Lippes loop and Grafenberg ring. The copper containing IUDs are known as second generation intrauterine devices, and examples include like copper T7, copper T220B and copper 380AG. And if the hormone is added to the intrauterine devices, it is known as third generation intrauterine devices. Examples include your progesterone and LNG IUD. So your non-medicated inert IUD is first generation. So your second generation and third generation IUDs are bioactive IUDs. So this is your Lippes loop, this Grafenberg ring, and these are not used nowadays due to high expulsion rate and lot of side effects. These are all examples of your second generations copper Ts, copper T200, multi-load 375, copper T380A. And this is your third generation LNG IUD, and there is a steroid reservoir, and this is the knob, arm and the strings attached to it. So the numbers we are talking about like 7, 220, 380, these represent the surface area of the copper in square millimeter on the device. Number A, B, C, D represent the size of the IUD, starting from A being the smallest size and D being the largest size. So the different copper T have different lifespan and they are usually asked in your MCQ. So the copper 380A lasts up to 10 years and the copper 375 lasts up to 5 years. Multi-load copper 375 also lasts up to 5 years. Multi-load copper 250 need to be replaced in 3 years and Nova T380 need to be replaced after every 5 years. So the currently two types of IUCD, they are available under the National Family Welfare Program, like IUCD 380A, which is effective up to 10 years, and IUCD 375, which is effective up to 5 years. So both of these types are provided free of cost under the National Family Welfare Program. And they both can be used as an interval or the postpartum or post-abortion insertion. So what is the mechanism of action of intrauterine devices? So first is a foreign body reaction. So there are cellular and the biochemical changes in the endometrium and also changes in the uterine fluid. So these changes impair the viability of the gamete and it reduces the chances of fertilization rather than the implantation. So this is important, comes in your MCQ. So if you are added copper in the IUDs, what action it takes? It enhances the cellular response in the endometrium. It also affects the enzyme in the uterus. It alters the cervical mucus, which affects the sperm motility and capacitation and the survival. Addition of hormones in the IUD increases the viscosity of cervical mucus. It prevents the sperm from entering the cervix and thus make endometrium unfavorable to the implantation, having the high progesterone and low estrogen. Area for an ideal candidate IUCD are often asked in the Viva, and that includes the female at least who has born one child, has no history of pelvic disease, has normal menstrual period, she is willing to check the IUD tail, has access to follow up and the treatment of potential problem, and she is in a monogamous relationship. So the timing of insertion, so it can be inserted any time during the menstrual cycle if the female is reasonably sure that she is not pregnant, but the ideal time is after the 5th day and before the 10th day of your menstrual period. Different nomenclature have been used as per the timing of insertion of an IUCD. So if you are inserting the IUCD post-abortion within the 12 days of completion of surgical abortion, then it is known as a post-abortion IUCD insertion. And if we are inserting the IUCD within 48 hours of vaginal delivery or with the concurrent with the C-section, then it is known as a postpartum IUCD insertion. And if we are inserting the IUCD any time after the menstrual cycle or after the 6th week of delivery or after the 12 days of completion of abortion, then it is known as an interval IUCD insertion. So we will discuss in brief about the 3rd generation IUCD. So Progestasert is a medicated bioactive IUCD, and it was the first hormone intrauterine device which was developed in the 1976. So it is a T-shaped device which is filled with the 38 milligram of progesterone, and the rate of hormone release is 65 microgram per day, and the shelf life is 1 to 1.5 years. But now it is no longer being manufactured. Second one, we have a levonorgestrel intrauterine system. This is a T-shaped device, and the total amount of LNG is 52 milligram, and it is released at the rate of 20 microgram per day. So this is the steroid reservoir, and these are the different subparts of your copper T. This is a knob, arm, strings attached to it. So if we talk about the mechanism of action of 3rd generation, they act on the ductal, effect on the uterine lining, they also affect the cervical mucus, and they also affect the sperms. Advantages include these 3rd generation have a lower expulsion rate and lowest removal rate as compared to the 1st and 2nd generation, and there are less chances of the dysmenorrhea and menorrhagia. But the disadvantage include they are expensive, they require yearly replacement, and the chances of ectopic pregnancy is highest, and the failure rate of Progestasert is 2% per year. So apart from the contraceptive benefit, there are some non-contraceptive benefits, especially with your 3rd generation copper T devices. So that includes the significant reduction in the menstrual blood loss, menorrhagia, dysmenorrhea, and the premenstrual syndrome. It can also be used in the treatment of your endometrial hyperplasia, adenomyosis, endometriosis, uterine leiomyosma, and endometrial cancers. They are also be used as an alternative to hysterectomy for the menorrhagia or the dysfunctional uterine bleeding, and it also provides the excellent benefits of hormone replacement therapy when they are used over the transition years of reproduction to the perimenopause. So all these non-contraceptive benefits are sometimes asked in the viva. So once we have inserted the IUD, there are some indication where we need to remove the IUD. So first is if there is a persistent, excessive, regular or the irregular uterine bleeding and it is not resolved even after 3 to 4 months of use, then we need to remove it. If there is a flaring up of salpingitis or perforation of uterus and the copper T has migrated to the peritoneal cavity, IUD has come out of the place, there may be partial expulsion, or if there is a pregnancy occurring within the device in situ. And if the woman is desirous of a baby, or if there is a missing thread, we are not able to locate it, or the 1 year after the menopause, or when the effective lifespan of the device is over, then we need to remove the IUD. So when the thread is not visible, there can be multiple reasons. Either the thread may be coiled inside of the uterus, or the thread may be torn, or the device is expelled outside which is being unnoticed by the patient, or the device has perforated the uterine wall and it is lying in the peritoneal cavity, or if there is a pregnancy, the device may be pulled up by the growing uterus in pregnancy. These are the possible causes of a missing thread when the female is not able to locate the thread. So how to identify the missing thread and the location of that IUCD? So first we have to exclude the pregnancy, and we can do a ultrasonography that can detect either the IUD within the uterine cavity, or it may have migrated in the peritoneal cavity if there is a perforation, and it is preferred over radiography. Or we can do a hysteroscopy that can be used for the direct visualization of the uterine cavity, and simultaneously we can remove the IUD as well. Or we can do the sounding of uterine cavity by a probe. So what are the absolute contraindication and relative contraindication in which we will definitely not prefer the insertion of IUCD? So the absolute contraindication include the suspected pregnancy, the pelvic inflammatory disease, any kind of bleeding or vaginal bleeding of undiagnosed etiology, the cancer of cervix, uterus or adnexa, or the other pelvic tumors. And as the IUCD can have an increased risk of ectopic pregnancy, so if there is a previous ectopic pregnancy, we will not prefer the IUCD insertion. Relative contraindications include anemia, menorrhagia. So these are the common side effects of your IUCD insertion. There is increased uterine bleeding. There may be bleeding in between the periods. So we will not prefer in the patient who are already having these problems like anemia, menorrhagia, history of pre-ID since last pregnancy, purulent cervical discharge, distortion of uterine cavity due to the congenital malformations of fibroid, and if the person is not willing, she is not motivated person, because we need to check the tail regularly from time to time if the person has accepted the IUCD insertion. So these are absolute contraindications and these are your relative contraindications. So what are the various advantages of using in copper T? And it is provided free of cost by the Government of India, and the technique is very simple and it is cost effective as well, and it provides a prolonged contraception like 5 to 10 years, and it is suitable for the rural population as well, and it lacks any kind of systemic side effect which we see in the case of your oral contraceptive pill. So they are also suitable in the persons who are having hypertensives, breastfeeding women, epileptic women, and the reversibility is prompt if after the removal of an IUCD. Disadvantage includes it requires some sort of motivation to need to check the tail regularly. It increases the risk of ectopic pregnancy, and there may be some local reactions like menstrual abnormalities, PID, pelvic pain, heavy periods. But these side effects are quite less as compared with the third generation of an IUD. So the failure rate of an intrauterine device ranges from 0.1 to 2 per 100 women years.